hello, everybody. I'm very excited to be here, and thanks for the invitation. I'd like to talk about infant sleep for a minute here, but I don't know if you've been to a bookstore lately around the health or parenting aisle. You may have seen the massive number of self-help books about infant sleep, some less questionable than others. And it seems that when it comes to infant sleep, many parents are looking for help. Infant sleep is a major concern, mainly due to the fact that it's highly fragmented and unpredictable. And it's scattered around the day and night in short episodes, which makes it really hard for parents to have a consecutive sleep episode. And around 20 to 30% of infants and toddlers are diagnosed with behavioral insomnia of childhood, which presents as difficulties initiating and maintaining sleep, frequent awakenings during the night, insufficient sleep, and dependence on parents for sleep. And these problems tend to persist if untreated, and their consequences could be highly adverse. So naturally, many parents want to do something about them. Now, fortunately, there are behavioral sleep interventions, or BSIs, that are available, and these are based on learning theory, where parents try to recondition sleeping cues to facilitate self-regulation and independent sleeping in their kids. And randomized clinical trials have repeatedly demonstrated the effectiveness of these brief interventions in improving infant sleep without evidence for harm. However, randomized clinical trials provide only a partial account of BSI's impact on infants and their parents, since these trials' eligibility criteria usually they dictate that only the most severe cases are included, and implementation is only within a clinical research setting. But we know that parents implement these interventions on their own, outside the clinic, outside a research setting. So what does the data tell us about real-world implementation of BSIs? So a 2018 study by Honecker and colleagues investigated BSI use in a real-world setting. And this study recruited 652 parents, most of which were mothers, from a sleep training Facebook group. And the online survey administered asked about parents' experiences with 3 common variations of BSIs. The first was unmodified extinction, also called cry it out. This was defined as a parent putting the infant in their crib, leaving the room, and not returning to check on the infant until the morning wake-up time. Modified extinction, also called controlled crying or the Ferber method, and this was described as an approach in which parents leave the room, but then return at set intervals. So if the baby cries, you return to check in, maybe pat, do a little shush, go back out again, and if the crying continues, you continue to check in. And finally, parental presence, also called camping out, where parents stay near the infant's crib continuously, but provide reassurance at set intervals. So they wait a few minutes before they do the shush and the pat, but they're in the room the whole time. And Honecker et al. Study found that parents retrospectively reported improvements in their infant sleep following all types of BSI, so they found no differences in the type. And the study provided important evidence for the beneficial effects of BSIs when they're implemented in the real world out there. However, as all studies, it also had several limitations. So first of all, they only recruited parents who have implemented BSIs, not parents who hadn't. So there was no way to compare infant sleep of parents who have and haven't implemented BSIs, or to assess the frequency of use of these interventions in the real world. Parent well-being wasn't assessed, despite studies showing strong links between infant sleep and parent sleep, and depression and sleepiness. And also, it's been argued that BSIs can have undesired side effects, with the strongest criticism against these interventions saying that they may harm the parent-infant relationship. And while studies to date have not found evidence for these claims, it's important to continue and examine and investigate these relationships. And so we wanted to do that. And finally, parent reports in Honecker et al. Study where infant sleep was reported by parents. So parent reports are, of course, always subjective and possibly impacted by recall and social desirability bias. And that's where the Nanit came in. And for us sleep researchers, this is really a pretty exciting new tool to get objective sleep data, and as Natalie mentioned, at scale. So you've already heard about it from Natalie and Liat. I won't tell you again about the camera, but really the naturalistic, non-intrusive, validated automatic way to really reach a large sample and obtain objective infant sleep metrics is pretty priceless for us. And using this technology within a large sample, we aim to find answers to some important questions. So first of all, is BSI implementation associated with objectively measured infant sleep? How many parents use these interventions? When do they use them? For how long? How difficult and helpful do parents find these interventions? And finally, is BSI implementation associated with parent sleep quality, sleepiness, and depression, or with the parent-infant relationship? So we recruited 2,090 infants aged 3 to 18 months. So their parents were users of Nanit camera monitors. Most of the parents were mothers from the USA, and most had moderate to high household incomes and education levels. The design was cross-sectional. These parents gave consent for us to obtain their infant sleep metrics from the previous 14-day period. So we had 14 nights of objective data, and they completed an online survey, which included their experiences with BSIs. So we asked about the same 3 methods that I showed you earlier that the Honecker study used. They also completed the PSQI to assess their sleep, the Epworth to assess their daytime sleepiness. They reported their depression levels on the EPDS. We assessed parent-infant bonding using the postpartum bonding questionnaire with items such as I feel close to my baby as opposed to I resent my baby. And finally, they provided information about their demographics, infant age, gender, room sharing, breastfeeding, parent education, and other demographic characteristics that we wanted to control for in analyses. So what did we find? First, that BSIs were highly prevalent. 64% of parents in our sample reported implementing at least one method, with modified extinction leading. That's the blue bar that you see here, with 43% of parents reporting that they had implemented it. Next came unmodified extinction, and 10% had used parental presence. And what was also interesting was that the mean age of implementation was younger than we'd imagined, only 5.3 months old, so younger than what clinical trials usually include and younger than what is usually recommended. And there were no significant differences in infant age between BSI groups. So it wasn't that the implementation of a certain intervention was more common in older or younger infants. Next, we tested how long these were implemented for. So I'm showing you the box plots here, and adjusted negative binomial modeling showed that parental presence was implemented for significantly longer durations. This is the yellow bar that you see, or the yellow box. And it also took longer to see improvement compared to unmodified and modified extinction. Parents rated parental presence as less difficult, again here in the yellow. Less difficult, but also less helpful in consolidating infant sleep than unmodified and modified extinction. And there was not a difference in difficulty between the two extinction, the unmodified and modified extinction. They were equivalent in difficulty, but the unmodified extinction was actually rated as more helpful. And now, for the main research question, was BSI implementation associated with objectively measured infant sleep? The answer to that seems to be yes. And here we also could compare infants of parents who have implemented BSIs to those who haven't. So we have an extra bar here, the gray color. And looking at nighttime sleep duration, there was a strong main effect for group. Post hoc analyses showed no difference in the duration of sleep between infants whose parents tried unmodified and modified extinction. So the blue and green bars, again, were pretty similar. However, these infants had about 19 more minutes of sleep per night on average compared to those who hadn't tried BSIs, and about 25 more minutes per night on average compared to those who tried parental presence. And we found similar results for infant nighttime awakenings and for parental nighttime crib visits, where extinction groups were linked with more consolidated sleep compared to the two other groups. So fewer awakenings, fewer visits, for example, here in the green and the blue compared to the yellow and the gray. Now, the final finding I'd like to show you addresses the question of how these interventions were related to parent well-being and the parent-infant relationship. And despite some descriptive differences that you might see here, we found no significant effects for BSI groups on any of these measures. So parents who've tried certain interventions were not more or less sleep disrupted or sleepy or depressed than those who tried others or who hadn't implemented BSIs at all, and there was no difference in parent-infant bonding between groups. So it seems that BSI implementation was not associated with these parental factors that we measured. To sum up, BSIs are common, and parental presence was implemented for longer periods, took longer to see improvement, and was rated as less difficult but also less helpful than unmodified and modified extinction. These latter two were associated with longer sleep duration and fewer nighttime awakenings and fewer parental crib visits. So we could interpret this as higher effectiveness. And importantly, parental sleep, daytime sleepiness, depression, and bonding with their infants were not associated with BSI implementation, not for the better and not for the worse. It's important, of course, to bear in mind the study's limitation. As any study, it has some drawbacks. So first of all, the design was cross-sectional. We can't really conclude anything about directionality or causality, as opposed to what we could do if we, when we run RCTs, randomized clinical trials. Our sample was quite privileged, which may limit generalizability to some extent. And mainly implementation of BSIs occurred at various infant ages. So there were between 0 and 12 months going by from when implementation occurred to when participation in the study occurred, and we controlled for infant age and added it as a potential moderator, but the variability in time lapsing from implementation to data collection still, of course, calls for caution in interpreting our findings. But for now, we still want to send you home with a couple of messages. So very common to implement BSIs. It looks like implementation of BSI is associated with more consolidated and longer nighttime sleep in infants. And as RCTs before, the study also did not find any evidence for harm or benefit for the parent well-being and parent-infant relationship. So this provides some further support for their safety. I'd like to thank my wonderful colleagues on this project, which you'll see tonight or have already seen. Thanks, Natalie, and thanks, MG, and thank you for your attention.